Hello, I'm Faith Rogers, host of today's program, COVID-19, Keeping Up with the Moving Target. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC, AAPA, and AMA-PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the Claim Credit button on the webinar console. Otherwise, please go to covid19.dkbmed.com, navigate to our multi-specialty episodes, and select the webinar to claim credit. Today's learning objective is to discuss effects of vaccines, including boosters, on risk of severe COVID-19. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, as well as in-kind support from DKB Med. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. Dr. Auwaerter, thank you so much for your time today.
Thank you, Faith. Many parts of the United States have been seeing declining numbers of Omicron infections in the community. Hospitals have hopefully fewer patients, but there's still many parts of the country where infections may still be causing a significant strain on hospital resources. Over the past, now going into the third month since we've been handed Omicron, starting in November of 2021, we're getting a better sense of the impact of this particular variant, which has become dominant in the United States, representing over 99% of sequenced isolates. The National Health Service in the UK, because of their standardized approaches to care and coordinated data collections, has been helpful to try to get a sense for what the SARS-CoV-2 pathogen has done in terms of human health. And I think you can see the sense that the original Wuhan, the ancestral strain, and then if you look at January of 2021, the Alpha variant had significant lethality of over 1% of people infected dying, at least in the United Kingdom, which previously held one of the records, at least for industrialized countries, with the highest death rates. But what's happened really through the spring and summer of last year, and now in the fall, you can see decreasing fatality ratios of infections, such that now it's approximately twofold more severe than seasonal influenza. Still nothing to be sneezed at, of course, and in an average influenza year, estimates are anywhere from 12 to 60,000 deaths. So you can certainly do some math for the United States there. But importantly, just recently, the United States has surpassed Britain in terms of having the highest number of deaths per population. And this may be from a number of factors, but probably is mostly related to still a substantially under-immunized section of our population. Now, turning to the United States, the Centers for Disease Control has compiled some data, again, just over the past 2 months, that has really been remarkable. I think everyone realizes that the contagiousness of Omicron was just really astounding. And the number of cases per day crested at nearly 800,000. And even though it appears to be milder, the number of infections increased nearly twofold, but still, luckily, nothing as if we had Delta or earlier variants with those numbers. I think we would have seen substantially more impact on hospitals, patients, and deaths. So certainly where community rates are still very high, it's prudent to be cautious and take mitigation measures. But one of the things that has become increasingly apparent is that if you've had your mRNA vaccines, and that's Pfizer or Moderna, but have gotten additional dose number 3, as it were, the ability to prevent hospitalization seems to be increased rather dramatically. So You can see for immunocompromised people that might be at most risk, those people that started to get third doses back in August elevated their protection from hospitalization. And then for people that are immunocompetent, the booster also got it up to nearly 90%. You might say that looks a bit less, but remember, many people here may have gotten boosters at different times than people in that earlier group. But the big picture message here is that you get a substantial level of additional protection by getting that booster dose. Now, unfortunately, this message, I think, still is not yet resonating with our patients or the public to the degree that it ought to. The number of average weekly deaths, I think, tells this story better than any other means. If you're completely unimmunized versus those people that are either immunized or have gotten a booster, you can see such a substantial decrease in your likelihood of death. Unfortunately, the number of adults who have been boosted in the United States stands no more than 30% based on estimates, and that's lower than other countries. So again, we're a bit behind given the amazing abilities of these vaccines to prevent serious infection, hospitalization, and death. It's a message that we hope to really tell our patients, and hopefully this kind of information can help convince people with little doubt that immunization, but especially if you add on booster or additional doses, prevent serious illness and hospitalization as well as death. There's little doubt that prevention is the key here. Although we have treatments, those are imperfect at best, and playing catch up, which at times is still yet a very serious infection. And although we hope there will not be new variants, being prepared for such immunizations give you the best chance as well. So Faith, we have some questions.
Yes, we do, and thank you so much for that information. Our first question here is, what do we know about the relevance of the BA.2 variant?
Yeah, the BA.2 variant seems to have been derived from Omicron and was first identified also in South Africa, like the Omicron variant. Some early data from Denmark suggests this variant's even more contagious than Omicron, maybe about 1.5 times that of Omicron. Now, whether it causes more severe illness or not is not clear. This particular variant has 32 of the same mutations as Omicron, but 28 different ones. And again, some data has suggested that actually our vaccines might respond better to the BA.2 variant than Omicron. So I don't think there's much concern yet about BA.2. The WHO has not labeled it a variant of concern. It has been identified in over 50 countries and in at least half of the states in the United States. So there'll be continued monitoring on this question, Faith.
Very good to know. Thank you so much. Our next question is, what are the advantages and disadvantages of the Novavax COVID-19 vaccine compared with the others?
Yeah, Faith, the Novavax vaccine had very high hopes early on. This is a protein subunit vaccine, very similar to hepatitis B, the pertussis component, and the tetanus, diphtheria, acellular pertussis vaccine. So it has a long history, but is complexed with an immune adjuvant that really gave some of the highest antibody responses in early phase trials. There have been some manufacturing and other clinical trial issues, so they're a little late to the party here. But this is a 2-dose vaccine. It's also one that only requires standard refrigeration. It looks from the New England Journal article from this past fall, when the phase 3 study results were published, that has about a 90% overall vaccine efficacy, which is certainly in the same neighborhood as the mRNA vaccines. Also, some other preliminary data suggests that people who have gotten the Novavax immunizations do have activity. Their SEER has activity against the Omicron variant. I think where this role is important, even though obviously so many people have been immunized, for those people that may be hesitant to get mRNA vaccine, thinking that it's a new kind of vaccine or one that they have some caution or fears about, it does give another alternative. This is one that is more in the tried and true department, so may have some attractiveness if the FDA clears it for emergency use authorization. Also, there are some people, rare, but have reactions to vaccines, either the mRNA or the Johnson & Johnson vaccine. So it again gives us another alternative. So I think it will be welcome. We don't know, or it's not been indicated yet, whether the FDA will put together an expert panel or authorize it just based on their own internal review.
Okay, fantastic. And here's our final question today. What are your thoughts about the rolling submission for the Pfizer BioNTech vaccine for children under 5?
Yeah, so the reduced dose of the Pfizer mRNA vaccine, I think, used a 10 microgram dose for children under 5. And this 2-dose series oddly worked, or at least seemed to cause sufficient immune responses in children 6 months to 2 years, but not in the 2 to 4 year age range. And what Pfizer is proposing is that even though there are issues with their pediatric trial in this age range, they are asking for emergency use authorization while their clinical trial examining the role of a third dose is in progress and may not be reported until late March or thereafter. So this is rather unusual. I think it's probably unprecedented that the FDA would face this. So the FDA is based on probably extrapolating from what's happened in immunodeficient patients and others, thinking that a third dose may do the trick. Regardless, the FDA is putting together an expert panel for review in the middle of February. And of course, then it still needs to go through the CDC and the ACIP process. So I think this is not necessarily a done deal and will likely be controversial.
Okay, thank you again for those updates, Dr. Auwaerter. If you're tuning into our webcast, please click the Claim Credit button in the webinar console to attest for credit. Otherwise, please visit us at covid19.dkbmed.com. Again, thank you for joining us and thank you for your dedication to your patients with COVID-19. Thanks again, Dr. Auwaerter.
Yeah, thank you, Faith, and hope you are all well, and we'll have additional programs soon forthcoming.